Okay, I think we make a start slowly. There might be still some people drifting in. So thank you all for coming today. My name is Michael Hornberger. I'm the Professor of Dementia Research here at UEA. And we run this Dementia Open Forum 4 times a year. Some of you might regularly come. And we have a bigger event usually in June. And part of this Dementia Open Forum is really to showcase research that is happening at UEA and trying to get it out there in the community, getting out of our ivory tower, even though we're still doing the event in the ivory tower, but there you go. So just some housekeeping. So no planned fire drills today. So in the event of a fire, please exit the lecture hall and make your way to the nearest stairwell and keep a safe distance from the building. Of course, there's a building site on the opposite, so it's quite tricky. The toilets, if you go out here and turn them right, they're the toilets. And the parking tokens, so on the registration desk, if you haven't got your parking token validated, please do that so you don't have to pay for parking. And that's the housekeeping. So it's my great pleasure to introduce Tamara Backhouse, who is an Alzheimer's Society Research Fellow and is doing particular research in care in advanced dementia, which is very topical, which we can see loads of people very interested in this. And she's talking today about her personal care in advanced dementia, working towards reducing refusals. Thank you.
Okay. Thanks. Let's get my slides up. Okay. Thanks, Michael. And thank you all for coming. It's great to see you all here. So I'm Tamara Backhouse. My background is in care work, so working in nursing, residential and very sheltered accommodation care homes for older people, some with dementia, some without. And I've done that for many years alongside my studies as well. So today we're going to talk about assisting people with dementia with their personal care and hopefully working towards reducing refusals of care. So first we'll talk a little bit about what are refusals of personal care in dementia, and then look at a little bit of care home data from my PhD research study, and then look at the current advice that's out there on offer for carers of people with dementia and some of the interventions that are used within research. And then I'll finish off by talking about the ProCare study, which is a study that's now started recruiting in this area to hopefully find out a bit more and develop an intervention. So what are refusals of personal care in dementia? So assistance with personal care is physical support given to the person in connection with their eating, drinking, toileting, washing, bathing, dressing, oral care, or care of the skin or nails. And to that, I also look at medication administering as well, helping somebody. So refusal behaviours in relation to assistance with personal care, they can cover many areas. There's many types of refusal behaviours that caregivers may encounter. So the person with dementia may verbally refuse some help, saying no, or they may stiffen their body, so it's difficult to get clothes on or off. They may push things away, perhaps the flannel or toothbrush, or be verbally or physically aggressive in the interaction. They could also grip onto things or tug things like the caregiver's clothes or a towel, something like that, or lean or look away to sort of show that they're not really happy with the interaction. They could become visibly upset as well and perhaps cry, or maybe in terms of teeth cleaning, something like that, they may clamp their jaw. They may ignore offers of assistance, or they may not physically cooperate, perhaps make their body heavy, and all these are quite difficult for the caregiver, but also, obviously, the person with dementia themselves is not feeling very happy with the interaction. So refusals of assistance with personal care are most common in the severe stages of dementia, and they occur in family settings, hospital settings, and care home settings. So they're quite prevalent. And there's lots of reasons for refusals. So perhaps the person with dementia doesn't understand the caregiver's intentions. So we can all identify with that. If somebody came to perhaps try and undress us and we weren't sure what they were trying to do, I think we'd all feel slightly affronted if someone was trying to undo our buttons or something like that. There may be environmental factors as well. So perhaps the room is cold or it's noisy and the person's feeling a bit disturbed. Their health status, such as they may have a urine infection or a cold or something like that, would make somebody a bit more reluctant to receive some help. They may have delirium or depression, or having delusions, thinking that somebody's trying to hurt them or something like that. They could be in pain or have other unmet needs. Also, it could be quite embarrassing for the person with dementia as well, in terms of some of the intimate personal care. And the caregiver approach as well could cause a reason for a refusal. If somebody was very abrupt or very quick or noisy and the person didn't feel comfortable with that. And as part of this, elder speak, which is when somebody speaks slowly or uses more simple sentences, perhaps overly endearing terms, or maybe speaking to the person as though they were a child, that has been found to cause instances of refusals of care. So it's quite a difficult area, really. So I'm just going to look at it a bit more. So refusals of care are quite distinct from general behaviours. So somebody could be agitated in their day-to-day life, or restless, or perhaps slightly physically or verbally aggressive. But the refusals of care always happen around that interaction of personal care. So there's always a caregiver and the person with dementia. So it's to do with the interaction, and it's a reaction against the interaction usually. So somebody may be agitated all day, but we're talking about agitation in response to an interaction about having some care. So we usually start off with a person with dementia, a caregiver, and they're within an environment. So there's lots of factors already there. And then the caregiver will attempt to assist the person with their personal care in some way. And this could be quite acceptable to the person with dementia, and this is what we hope. A nice, acceptable interaction and care is delivered, and that's absolutely fine. That's the aim. Or it could be quite unacceptable to the person, perhaps, for some reason. And the caregiver may employ a care strategy, like a distraction, or perhaps singing, or encouragement, and then care delivery may occur. Or the care strategy may not work, and the caregiver may leave the person and think this interaction is too difficult at the moment, let's try again later, let's withdraw for a little while. But how long do you withdraw for, and how long do you leave that interaction when perhaps the person's wet or soiled? It becomes difficult, and there's lots of tensions there that obviously care is needed to be undertaken. Or perhaps in that instance, when you've left the person for a while, you may go back and use some controlled restraint to undertake the care. So maybe in a sort of forced care in a way, just so the person is clean for now. Because how long do you leave them? The tension is, it becomes a point, well, how much longer can I leave the person here, and what is their best interest here to do that? When do I step in? At what point do I intervene, or keep trying strategies, or leave, or actually have to deliver the care? So as you can see, it's a really, really difficult area for caregivers and for people with dementia themselves, obviously, if they're feeling that the interaction is quite unacceptable. So if there are refusals of care and no care is given, it could be a public threat to the person's dignity. They could be walking around in dirty clothes, they could be a bit smelly, a bit unhygienic, it may reduce their chances to go out for the day or something like that. So there's a difficulty there. They may have poor hygiene, or lead to urine burns, or pressure sores even, an infection. So if no care is given, there are some consequences for the person's health. But if care is given and it is an unacceptable interaction, there's that difficulty around the conflict and anxiety on behalf of both the caregiver, perhaps, and the person with dementia. It could be stressful, or maybe encouragement is given, or maybe coercion or distraction. And the ideal is the successful interaction. You may just get a successful interaction, which is the main thing. But on both sides, if care is given and there is a conflict, or if no care is given, it's quite distressing, and either way could lead to a crisis point. So it's just a real difficult area of tension within caregivers. So I'm going to talk a little bit about some care home data which I've collected during my PhD, and which led me down this route to focus on this area, this difficult area. So the aim of my PhD was to explore strategies used in care homes to manage dementia-related behaviours. So I wasn't looking at those refusals of care, I was looking at behaviours generally. So I sent a postal survey to care home managers in the east of England in 4 counties, so to 747. I had a 40% response rate of that, and as part of that postal survey, amongst other questions, I asked which behaviours did they find difficult day to day? What was difficult for those care home managers? And the second part of the PhD was 4 case studies in 4 separate care homes where I did some observations in the shared spaces, so not really looking at personal care delivery. And I interviewed care home staff where some of them did talk about refusals of care. And I also looked at psychotropic medications. So in terms of the postal survey, resisting care came up as the 3rd most difficult behaviour for that care homes found difficult to manage. But as you can see, aggression came out as the top. So we have no way within the scope of this survey of knowing if that aggression was during care or just a general aggression during the day. But those are the issues that we're sort of working on here. And then within the case study, the more qualitative data, generally I found that care homes were not using interventions such as aromatherapy, music therapy, and reminiscence therapy to manage behaviours or prevent them happening. They were using them to improve quality of life of all of the residents, regardless of behaviours or not dementia-related behaviours. And also, the care home staff were more concerned with the risks and impacts of dementia-related behaviours than they were the behaviours themselves. So, for instance, if somebody was walking around, or sometimes called wandering, that was absolutely fine. It's not a problem until that person perhaps walked into somebody else's bedroom, so had an impact on somebody else, or until they trying to leave the care home or go near the stairs where there was a risk to their safety. That's when the care home staff had to intervene. So often the behaviours were less of an issue than the risk or the impact on others that came around those behaviours. I also found a few questionable strategies maybe. Heavy monitoring of those with dementia-related behaviours, quite considerable behaviours. Positioning so that interactions with other residents didn't escalate, or so that they could be easier monitored. And also perhaps some controlled restraint to cope with some of the aggression and difficult behaviours. But in terms of resistiveness to care or refusals of care, some of the facilitators to help in this area were strong management and leadership. So, for instance, if the care home manager was quite happy to say to the staff, it's okay, that person's got their jumper on back to front or got a dirty jumper on, but when we're trying to change it, there's a conflict here and it's creating a tension. That's okay. It's not going to hurt anybody. The person's happy. It then allowed the staff to be empowered to do the care that they could do when they could and not have the tension in the interactions. So that really helped if there was a strong management, and it helped with the staff being more confident to do what they could at the time they could do it. In terms of the interviews, here are some quotes from people that I interviewed around refusals of care. So this is Jill, a care home manager, and she says, if we've got to do something and we know that somebody's perhaps unsettled or agitated, then we do the minimum that we need to do, and we walk away, and then we go back 10 minutes later and see how that person is. It's trying to get that balance around, you know, what's best for the resident. I don't have a problem if a resident, I don't know, perhaps is wearing the wrong clothes or an arm's not out. So here she's saying, do the minimum. If there's that point where care has to be undertaken, let's not make sure they have a whole bath. Let's just do the bare minimum that we can do and then leave the person and then check they're okay. And she also spoke very much about we need trust. We need to keep that trust with the resident. Here, Carla, who's a senior care worker, she says, it always seems to be on contact when you're trying to do something they don't want to do, but it's got to be done because they're wet or they're soiled. As soon as you're finished, they've forgotten it. It's just that moment. You're talking to them, trying to reassure them, we're just going to change you, you're all right, make you comfortable if you just sit quietly, it will be done in a minute. But of course, they don't understand. So again, we've got this, it's got to be done. Something has to happen here. We can't leave this person much longer because they're soiled or wet. But also, an acknowledgement that you do try to reassure the person, that, you know, try to make that interaction okay. And here Natalie and Christine, two care workers, are talking. It's normally a change of face sometimes does it. So yeah, you can go back 5 minutes later and the person be totally different. Or somebody else can take over and they're just calm. So one of the strategies care home staff were using was this leaving and going back to try again later. Or they would say, oh, do you mind having a go and see if you can get anywhere where I couldn't. So that was some of the strategies care home staff were using. And here Elaine, a care worker, is talking. She says you use pillows against their bodies so that they're buffered. We're buffered, and that's the training the manager has shown us, because that's mostly when dementia people are at their worst. It's they feel embarrassed. We just get on with the tasks, but we know as soon as they're cleaned up and their pants are pulled up, like you or I suppose, they're fine. Because we've had residents where we do have to buffer, you know, we don't like doing it. So here, and I must say for context that this was an elderly, severely mentally infirm care home, so they did have residents with considerable difficulties, and some of their strategies were for safety, to protect the staff and the person. But I think it's really important that Elaine points out that they feel embarrassed. And just like you or I, we would all feel the same perhaps in their situation. So I think that's a really important point. And just to say, these are all pseudonyms, they're not the names of the carers. So I suppose that piqued my interest when I was looking at my data and thinking, actually, this is quite a tension here that carers are having to cope with. And if it's not just in care home settings, it's in family settings too. What is the support? What's the guidelines? You know, what is there to help people? So we're going to look a little bit at the current advice and the current focus of research interventions now. So I've looked at dementia organisations. So these are the kind of leaflets or advice you'd get from Alzheimer's societies in Canada, Australia, UK, United States, or Alzheimer's associations, or care alliances. So these are all advice for caregivers. So about the caregiver approach, they say to be flexible, be calm, communicate throughout, perhaps adapt to the person's preferences and reassure the person, involve the person, and perhaps try later. And they also talk about humour, using humour and understanding as part of the approach. And in terms of the person themselves, they say to the caregiver, well, control their pain and maintain their general health. Perhaps try to reduce fear and embarrassment at all times, generate trust with the person, and try to let the person know what's going on. In terms of the environment, they say prepare for the task, so get everything ready before you start the care task. Make areas safe, so there's no risk of hurting yourself or the person. Check temperatures of the room and the water. Obtain the right equipment, so if you need bars to help the person stand, get handrails. And then create a soothing atmosphere, perhaps through music or aromas, or just being calm. Other factors, they state to say, have enough time to do the interaction, use familiar toiletries, or get help and support. So this is the sort of kind of advice you get. And in terms of individual personal care interactions, for bathing, they say use towels to provide privacy, so perhaps keep a towel over somebody's top half while you're washing their bottom half. Offer a choice of bath showers or washing. Try again later. Distract the person. They also say pat the skin dry instead of rubbing it dry. And perhaps use no rinse soap, so it's a quicker task. In terms of dressing, they say choose simple clothing, simplify the choices you're offering the person, perhaps even purchase duplicate outfits so that if the person likes to wear the same type of clothes, you've got a substitute there and there's not one in the wash that's not accessible. And not to worry if the person's mismatched. Think what is the most important thing here. In terms of oral care, perhaps try an electric toothbrush. Demonstrate alongside the person, so clean your teeth in sync synchronise with the person. Perhaps guide their hand or use a dry toothbrush. And maybe just use the upper denture as well, as mentioned. In terms of eating, they say try not to rush the person. Use finger foods. Try not to let food go cold. So serve half at a time and perhaps keep the other half warm if somebody's a very slow eater. And let the person eat where they would like to eat, not enforce the table. Medication, they say to give the most important medication first. Perhaps see the prescriber and see if there's a liquid rather than a tablet or a patch. And try different situations in terms of giving medication. But in general, they talk about persons' preferences, reducing embarrassment and ensuring privacy. So then when we look at the... I forgot toileting. So in terms of toileting, they say prompt regularly and use perhaps a contrasting colour toilet seat so the person can see the difference. Keep the route to the toilet clear and use incontinence aids if needed. So in terms of previous research, we're in the middle of a systematic review of the literature at the moment, so I'm afraid I won't be able to tell you the effectiveness of all of these interventions, but I can tell you that which interventions research has focused on up till now. It is work ongoing, I'm afraid. So the focus of previous research includes towel bathing, which is where you have a damp, warm towel and put it over the person and massage it, so the person might still be in bed. And there's been some research looking at that technique. And person-centred showering, where you're using the person's preferences and adapting your practices to their preferences and their choices. The researchers looked at singing through morning care and also indeed humming through care as well to try and make it be a bit more acceptable to the person. And threat reduction strategies within oral care. So these would involve coming down to the person's eye level, so you're not leaning over them, generating a good rapport with the person, using gentle touch and smiling, distracting the person perhaps, and using encouragement as well. So this one's an interesting one, the video-stimulated presence of a loved one. So this was a study involving somebody who was refusing to eat anything much. So their loved one was video recorded with encouraging messages to the person, and then the care home staff would play this at a meal time, and it seemed to work. I think it's a one case study for just one person, though, the research, so there's not much evidence there. So they're saying choices for bathing, using shorter baths or washes instead of a bath. More research has been done on reducing elder speak and seeing if that has an impact on the refusals or not. And educational courses for staff, using a person-centred approach. Also using positive instruction. So these are around compliments, approvals, doing things in collaboration, not to the person but with the person, and getting the person's agreement, so getting them on board with the task. There's been research around essential oils and touch, so aromatherapy, and also natural elements. So these were in terms of bathing. They would use pictures perhaps of birds or sounds of birds. There may be smells or foods also during bathing. And the caregiver would chat about these pictures, this stimuli, and try to use it perhaps to stimulate the person while they're being bathed or to distract them from the bathing process. So unfortunately, I can't tell you which of these are effective or not effective at the moment because we're just at the point of finalising our inclusion, so I haven't extracted the data. But there's an idea of what research is focusing on in this area. But there was a best evidence review by Conno back in 2014. It was published, but they searched the data up to 2012, and they found that in care homes there's a low level of evidence of music during meal times and during bath and shower time and to reduce refusals. And they found some evidence of a person-centred approach reducing refusals during bathing and quite weak evidence of an ability-focused approach during morning care. So an ability-focused approach would be maximising the person's own functioning, what they can do, maximising their independence, and using a supportive environment to do that. So all the research on the previous slide and these top 3 bullet points here, they're all to do with care home. They're all set in care homes or nursing homes. And there's very limited research set in hospital settings. There's some research showing that refusals happen, but there's no intervention research set in hospitals that we've found so far. And there's also limited research in family settings. Just one study we found with slow stroke massage being used to see if it reduced refusals of care. So now I move on to the ProCare study, which is the study that's recently started recruiting here at UEA, and we're looking into this area a bit further. So the study is called Reducing Resistiveness and Enhancing Engagement in Personal Care in Severe Dementia, ProCare for short. And it aims to determine the factors influencing refusals of personal care in advanced or severe stages of dementia, in family and in care home settings. And we also want to investigate the understanding and skills that caregivers have, because there's a lot of knowledge and strategies caregivers are automatically doing. They're adapting their approaches. They're quite highly skilled in the interaction. We want to tap into that and get an in-depth understanding of what is happening. And then we want to use the knowledge from the literature and from the quantitative stage and the more in-depth stage to develop some intervention or training or bespoke guidance. So the first stage is the questionnaires, and these are informant-based measures. So these will be asked of a caregiver. So we're recruiting dyads. We're recruiting a care home resident and a care home staff member who looks after that person, usually a couple or a few times a week. Or we're recruiting family carers and their family carer who help them with some kind of personal care interactions. And we're looking for people over the age of 65 in moderate or severe stages of dementia as well. So the caregiver fills in lots of questionnaires with the researcher, and this is to determine the factors influencing resistance to care. And the second stage is a more in-depth stage of interviews and observations to explore caregivers' existing understanding. And then we're going to bring all the results of the literature and those stages into some workshop consultations to develop the content of the training and also the format of the training. I have an advisory group throughout who are involved and enhance the research as we go along, and also the literature will feed in along the way. So when we look back at our refusals of care, we're very much looking here for the factors that may influence resistance. So our questionnaires are focusing on here. What are the factors here, and are any of these modifiable? So can we change any to help the interactions? And we're also focusing with the observations and interviews on this interaction and this interaction. But we're not sampling just people who do refuse care. We're very interested in those who don't as well and what's happening there, and perhaps we can learn across the two. So these are the kind of factors we're thinking about with our questionnaires. So we're thinking about refusals of care, obviously, and neuropsychiatric symptoms, so the person's usual behaviours, that is, their functional ability, so how they can perform everyday tasks, what can they still do, what's their abilities, and also their comorbidity, so other additional diseases or disorders there, and their health status. So they're the factors we're thinking about with the person with dementia. And in terms of the caregiver, we're looking at a caregiver approach and also the challenges that caregiver feels and their training needs, along with their confidence. So how confident do they feel assisting their loved one or the person they look after in the care home with their personal care? And how confident do they feel if there are refusals? We're also looking at the environment and support, so the bathroom environment, the bedroom environment where the care takes place, and also the use of support services. What support is that dyad getting? In terms of the observations and interviews, So we'll be observing some of the morning care routine. So this would be when the person's covered. We won't be observing toileting or bathing, but perhaps shaving, teeth cleaning, hair washing, final stages of dressing, those kind of things. There'll be non-participants, so the researcher won't be involved in the care, but will be an extra person looking on. And in some of those, we're hoping some people will be happy to be video recorded so that we can do a really accurate analysis and really hone in quite in depth to the interaction. And also we're doing interviews which will be face-to-face with the caregivers and perhaps the person with dementia if they're able to talk about what it's like to be helped with their care as well. So these will be in depth and semi-structured so the person can talk about their own experiences and we can follow up on the issues that they raise. So hopefully from this we'll get quite a lot of understanding about what's happening and how it is for the people involved. So after this, we'll be using our workshops to develop an intervention or probably training, but maybe an app, we don't know yet. So the first set of workshops with caregivers and professionals or people receiving care would be to determine the key issues and priorities from our findings, but also from the literature. What do we want to include in this? And the second stage would be how do we want to deliver the training or deliver the app? How can it work best? So everything will feed into this intervention. And as I've said before, we have some patient and public involvement involved with our study all the way through. We have a fantastic care home that allows us in to talk to their residents and care home staff member who comes out to the university to feed in, and also a family carer. So they're consulted at regular intervals, usually about 3 monthly, actually, and they've already commented on the documentation that the study uses. They provide advice to make sure the research is applicable to the people who are being researched, and they're very keen on undertaking some of the data analysis, especially of the observations and interviews, which will be pixelated if they're videoed and anonymised. Also, they will take part in workshops and maybe in some dissemination. So I have got, if anybody's interested in joining the advisory group, we could have room for another couple of people. So there are some leaflets outside if you want to just get in touch with me. And the outcomes and hoped impact from the study are obviously some kind of intervention or training at the end, tailored to specific care tasks. An assessment so that we have a good validated questionnaire about finding out of the refusals, about the refusals of care and how they impact people. Some educational materials, and then via the intervention further down the line, we're hoping that there will be improved care, increased engagement and perhaps less anxiety for people with dementia, and also support, guidance, more confidence, knowledge and empowerment for caregivers. So the study addresses some of the James Lind dementia research priorities around managing behaviours that can be quite difficult and supporting carers. That's some references. And I just wanted to thank my supervisors for both my PhD and for my fellowship, and also my colleagues helping me with the systematic review. So thank you for listening.